Everyone, welcome to Alliance Orthotics online education platform. So it's Dean here. I can't wait to share this one with you all. Today's case is a really interesting one, and it's one that involves the assessment and treatment of the pes cavus foot type. So as you can see, today here are the topics we'll cover. We're going to be assessing a recent patient of mine with a pes cavus foot type that's experiencing lateral ankle pain. We're going to be diagnosing and treating the patient's pathological mechanics and symptoms. So guys, this particular patient was a 28-year-old female who presented with left lateral ankle pain for roughly 3 months duration, and she had no known mechanism of injury, which basically suggests that there was no kind of lateral ankle sprain or anything like that. She just gradually began to feel pain and discomfort in the lateral ankle region whilst weight bearing. She reported that she has had this pain in the past and it has occurred on both feet previously. In terms of medical history, we didn't find anything significant or relevant to the case. And the patient had no medical conditions and didn't take any regular medication. In terms of social history, this patient was a nurse who was working on her feet, long hours, and she was quite active. She enjoyed running casually to maintain good physical and mental health. She's been running for a few years now, and as I said before, she has experienced this pain in the past, but she was vague. She was sort of vague in regards to when and how severe the pain was. All right, so let's have a look at this patient's relevant non-weight bearing assessment results. So as we can see, the patient has obviously quite a pes cavus foot type while she was non-weight bearing, and we found that her ankle joint dorsiflexion range of motion was quite restricted. She had a bit of a hypermobile subtalar joint and calcaneocuboid joint, and I wouldn't say her talar navicular joint was restricted. However, she was slightly less mobile through the talar navicular joint in the first ray. And now this is obviously something that we see quite often with the pes cavus foot type. The first ray can often feel like it's almost fixed in that plantar flex position. And we found that this patient had tenderness upon palpation of her left peroneus brevis tendon and insertion. So around the styloid process, and slight weakness with manual muscle testing as well through the peroneals. All right, so this slide is key to this case. Here we're assessing the rear foot to forefoot relationship, and we can see that when this patient's feet are held in the subtalar joint neutral position, her first MPJ appears lower than her fifth MPJ. And this is probably more noticeable on the left side if you really look closely. So when assessing the forefoot to rear foot relationship, this is what we call a forefoot valgus deformity. So whenever we identify a forefoot valgus deformity, we can usually expect the weight-bearing foot to load quite laterally. And this is because, as we mentioned before, there's not a whole lot of range of motion in that first ray to achieve any kind of first ray dorsiflexion. So as ground reaction forces act against the first ray and the talar navicular joint as well, instead of the first ray dorsiflexing, the foot will just sort of take the path of least resistance instead, and it'll appear to invert whilst weight bearing. So let's keep this in mind, and we'll touch on this a little bit later as well. So, all right, just wait for this video to load. So here we're going to go through a bit of a gait assessment. Okay, so as we can see here, as soon as the heel strikes the ground, we get that obvious shift of weight laterally. So we're actually seeing a bit of a supination moment at mid-stance phase, or the shock absorption phase if you like. And this is typically where you would see a pronation moment, but instead, here we're seeing a supination moment. And I suppose we see a slight amount of late phase pronation during the toe off, but by this stage, the pathological process in this case has probably already occurred. So we can see here this is how the perineal muscles are being placed under excessive tensile stress, and ultimately it's likely what's caused or contributed to the injury. While we're here, notice the plantar surface of the feet as well. You can actually see the forefoot valgus position after toe off, and you can see the heavy lateral loading pattern. All right, so how interesting is this? We can see here that when we place a rear foot valgus wedge underneath the foot, we surprisingly have no effect on the resting calcaneal stance position. And you might have expected the rear foot or the calcaneus to appear more vertical in relation to the ground once we've done this. But if we think back to our rear foot to forefoot relationship assessment, we know that the rear foot position isn't an issue. The reason this rear foot valgus wedge isn't everting the calcaneus is because the plantar flex first ray is blocking that from happening. So you might refer to this presentation as a bit of a compensated rear foot varus, if you've ever heard of that term before. So how do we balance the forefoot so that the subtalar joint doesn't oversupinate? Let's have a look. So here we go. We can see here that when we add a forefoot valgus wedge, when the patient has a forefoot valgus deformity, it'll actually sort of fill up that space and prevent the rear foot from oversupinating. This is because we've filled up that negative space, and we've balanced out the distribution of force beneath the foot. So if we're to include a forefoot valgus wedge into an orthotic for this patient, we would see their gait drastically change. We'd see that the foot no longer supinates excessively through mid-stance, and therefore we'd be reducing the amount of tensile stress through the perineals. And ultimately, this will give us a better chance at rehabbing this injury through exercise rehab, exercise therapy, and preventing further injury in the future, which is also key because she has had this long history. All right, so here's another very interesting slide. And a big reason why we also say attention to detail when assessing patients is so important. Here we've got both the left and the right foot weight bearing, and there's a clear difference between the two. We see that the lateral arch heights of this patient's feet are very different. And I think as podiatrists, we often put so much emphasis on the medial arch, and we're always assessing the medial arch, but the lateral arch contour is just as important, definitely when you're treating laterally based injury. So we see that the left lateral arch is a lot lower than the right, and this is likely due to the more prominent forefoot valgus deformity on the left side. We talk with our clients all the time about the importance of accuracy with your foot, with your method of foot capture, and finer details like this may be the difference between a successful orthotic and an unsuccessful one. And it could be a big difference why a custom-made orthotic will always prove to be more superior to a prefabricated one. And if prescribed with mindfulness towards these kinds of details, you're more likely to have success. So what do I mean by that? If a detail like this is missed during your assessment, sometimes you may still get lucky, and it might not matter. But we find it's cases like these where the finer details do matter. Prefabricated devices, for example, are the same on both sides, and in reality, feet are generally not. And we need to be thinking about custom-made orthotics from all angles and in all planes. And considering all aspects, they aren't just, arch supports. So therefore, if you're casting the foot using plaster, for example, careful consideration is required to capture these differences. If you're using a 3D scanner, make sure it's a good one. If your scans aren't completely accurate, your devices won't be either. And here we've got two completely different calcaneal inclination angles, two different medial arch and lateral arch contours and heights, and two completely different forefoot shapes. So these things need to be accurately addressed in your foot capture and prescription. All right, so one of the more common questions we get asked here at the lab is in regards to arch heights in our orthotic scripts. In the script, we provide a feature that allows you to alter your arch heights by percentages. So, for example, with this case, the non-weight bearing and weight bearing arch heights of this foot are quite different. And this has got to be taken into consideration when you're filling out your script. Your arch height selection on the script will change, or should change, based on how you've captured the foot. I'll provide a quick example. In this case, if you're wanting to capture that non-weight bearing forefoot valgus shape, which will be important in achieving the desired clinical outcomes, especially in this case, you need the foot to be completely non-weight bearing. Now, however, if we make no changes to the arch heights of your plaster cast or digital scan, there's a possibility that the patient might find the device sort of maybe uncomfortable, or they might feel too much pressure through the arch. So this is an example where you might want to lower the arches slightly. So in regards to our script, if you've ever had a look at it, basically what the percentages mean is if you were to picture the traditional way of making orthotics, right? Take a plaster cast, you fill the plaster cast with plaster again, and you've got the positive cast. In regards to our script, say for example, adding 20%, that just means 20% arch fill. So you again picture the positive cast, you're filling up that arch with 20% height with plaster. So essentially what you're doing, you're lowering that non-weight bearing shape by about 20%. So this might be a consideration for this patient. Hopefully that makes sense. All right, guys, that brings us to the end of our short online seminar on assessing the pes cavus foot. So a few take-home points. Use your assessment to identify where the excessive supination is coming from and what is causing it. Is it a true inverted calcaneus? Is it a laterally deviated subtalar joint axis? Or is it a forefoot valgus deformity that's potentially causing a compensated rear foot varus? Pay close attention to detail when you're assessing the patient. And finally, your foot capture technique is everything when it comes to maximizing your chances of achieving the best clinical outcomes for your patients. All right, guys, stay tuned for more content for the team here at Alliance Orthotics. And thanks for watching, guys. And be sure to reach out if you have any questions. Thanks.